The right answer is here. And, okay. True or false? CT scans are not very good at detecting acute blood. False, right. Which side of the brain is this lesion? Right, so the right side. Near the midline, but it is on the right side. And now, do we say the blood is hyper-intense or hyperdense? Hyperdense, right. Hyperdense. And here's a area on the DWI that's hyperintense. Assume it would look dark on an ADC scan. What is this most likely to be? Yeah, ischemic stroke. It's most likely an ischemic stroke. So this is part one. We'll the next jump back to part two, which I already started to showing you the epidural and the subdural. Maybe everybody can take just a few minutes for a break, just to walk around or use the bathroom or whatever, and then I'll get this set up. We'll find the right one again. Now here, yeah, I ended up with multiple copies. I got it. Let's see, this one let's see which one. Okay, I went through epidurals, actually went through this already. Okay, I'll go with this. Oop, what did I do there? And,
the thicker one last.
yeah, if I just have time. In fact, I don't know if there's anybody, is there anybody following me?
What do you mean?
Yeah, after, I'm here too, I'm too, because I think I may have to run over a little bit, so, in fact, I'm gonna then stay for questions, because since Dr. Hussein can't be here, I'm gonna try to answer questions.
Want me to extend the recording?
Yeah, could you?
Yeah.
Because,
So right now it's running until 4:15. You want me to set it to maybe 4:30, or you want to go all the way to 5?
Why don't we go all the way to 5? Okay. Yeah, because I want to sort of make up for the fact that Dr. Hussein isn't here, and
just keep in mind they might leave because it's not on the calendar.
Yeah. No, I'll tell them it's only if they want more explanation for it. If they, in fact. And just to make the recording of it, I maybe will lecture to an empty room, but just to sort of make a recording of this.
No
Let's see.
How many more do you have to go?
This is a duplicate.
Oh, gotcha.
Okay.
Oh, did you open all of them?
No, I did. Somehow I got mixed up when I started in one, then I was going to switch to the other, and then I couldn't find it, and I was opening up this one, that one, this one. And let's see, where did I put? No, there's that one. Yeah. Here's his pathology, because on some of these I want to bring in his pathology, and then maybe I should open the clicker one, and then maybe I could then just sort of minimize it or something once I open it.
Yeah.
Here, wait a second. Let me open that from the desktop. I think I had one to open from the. Okay. Whoop. Come on, you.
Might want to just spread it out just a little bit. You want to give it a little more grippy area.
It's going to drive me crazy. Probably the clicker one. Yeah, that's the clicker. Now, do I have to do something like to reset it or something?
Let's just make sure. Let's go ahead and do a reset. Yeah. Just to make sure.
I don't know how this got here. I didn't bring this up here either, but it was, somebody was,
Might be from another day, maybe?
could be, I don't know.
All right, you're all set. So you got Hussein's here
Yeah.
and this one, and you're
Right.
gonna flip between those two probably.
Right, and I'll even flip into that. I mean,
Are you okay doing that? I'll
Yeah.
flip here, but-
yeah, I'm okay.
Okay.
I'm okay. Yeah. Yeah. Well, hopefully more will come back than this.
I wouldn't bet,
Yeah.
but you never know.
Yeah.
Usually what we see is it trickles
Yeah.
out this time.
Yeah. Yeah. Yeah.
It's, every year at the end of second year,
Yeah.
we just see the class size get smaller and smaller.
Right. Okay. Well, hopefully a few more people will come back, but yeah. Right. Well, I will lecture even if I lecture to an empty room, so I'm. Mm-hmm. Yeah. Yeah, I also brought Muji's stuff so that because I went over with Muji so that if they have questions, I can answer questions on Muji's stuff since he can't be here. Well, maybe this is everybody that's going to come back. Let's see, what do I do now to get this thing back on the screen?
You just go into slideshow view.
Yeah.
Yeah. If you go into slideshow view, it'll come back. It'll all come up.
Oh, it will?
Yeah.
Oh, okay. Didn't realize that. Okay. Well, hopefully everybody is back that's wants to come back. Here we're back at the epidural hematoma again, which at which point I jumped into the more basic stuff. So there's your subdural, there's your epidural. And another thing I should mention to tell the difference between the epidural and the subdural, you may not be able to see these that well on the scan, but you'll recall from your study of the skull at some point that the skull is not just one continuous bone, that there's these sutures between different parts, different sort of sub-bones of the skull. And there are certain points, and the dura, at least in adults, is sort of connected pretty tightly to the skull. So if you're above the dura, when the dura comes down like that, the blood is trapped between the suture connections. And that's another reason why it sort of bulges out like that. So this is probably a suture connection here, and this is one here, and this is your blood. And an epidural cannot ordinarily go through these like a subdural can. I mean, if it's possible if you just really ripped apart the meninges so that then you'd have a combination of both of them, you could rip the connections out or something like that. But it's very rarely done. So if something goes the whole length or even through where you know, I think that's a suture line where my arrow is there. An epidural wouldn't do that. So even apart from that, you can tell a subdural from an epidural. But now we'll go into a little more stuff, and we started on this too, but here I'll talk about excess water in the brain, excess fluid in the brain, or edema. And there are really three main types of this. There's cytotoxic edema, and cytotoxic is just what it says, that something has happened that has really made the cell sick, either toxic to the cell. It doesn't have to be a poison or something like that, but it could be. It could be due to a side effect of drugs. Probably the most common reason, though, is a stroke. The stroke takes away your supply of blood, oxygen, the energy source, and therefore the sodium and potassium pumps, which keep your ionic composition where it should be and the way it should be, those pumps start failing, and the result of it is you get a flow of fluid into the cells, and the cells swell up with fluid, and that's the cytotoxic edema. And that's an example like this, and it generally goes all the way very, very close to where the brain meets the skull, or gets very close to it. At least on the picture, it looks like it almost meets the skull. Usually there is not much in the way of gray matter left on the sides. There's a little bit here, but you tend to lose the differentiation you see ordinarily between the gray matter and the white matter, which is actually sometimes not that well seen on a CT scan anyway. But this is the most common type of thing, common type of edema seen in a stroke, cytotoxic edema. Though you can get, especially chronically after the stroke, development of some vasogenic edema too. And the vasogenic is the second type of edema. And what that's due to is that the blood vessels themselves become sort of permeable. There's at least a partial breakdown of the blood-brain barrier, and therefore fluid will seep through the blood vessels and get into the brain tissue. And the most classic example of that is a brain tumor. Most brain tumors tend to cause the blood vessels to do that, or they have new growth of blood vessels, neovascularization, which doesn't have a good blood-brain barrier. And so you get this vasogenic edema around the tumor. For example, here we have some contrast delineating the lesion. This would be the tumor. And then there's some edema, which generally doesn't enhance with the contrast. Vasogenic edema by the tumor. Here again is the white is probably the tumor, and then there's some not so white areas near the tumor, which is the edema. You don't see it too much there, but you see where this yellow area is. That would be some vasogenic edema. So some tumors have like huge amounts of vasogenic edema. Those have sort of smaller amounts. And then there's the third type of edema, and that's called transependymal edema, and that goes through the ependema of the ventricles. And I think that I brought, let's see, well, here where I'm outlining with the cursor here, you can see on the CT scan the darker areas near the ventricles. See around the ventricles, sort of like a little darker. What that is, in this case, a hydrocephalus, or too much fluid in the ventricles. There's high pressure here, and the pressure is physically pushing the fluid through. Yes. Oh, it doesn't show on. Huh. All right. Okay. Yeah. Here's the swollen ventricle, which you can have hydrocephalus without high pressure, but especially if there's an obstruction, you get high pressure. If you follow around, you sort of see here's about where the ventricle ends, and this dark area is some fluid that is getting pushed out, and you see it a little lesser here, a little bit here. You see it mostly there, transependymal edema. and actually in a situation in which you have many different cuts of this, and radiologists on their software, they can make it darker and lighter. I could do it in PowerPoint, but it'd take a long time. You can bring sometimes the contrast out better, but do you see that sort of thing pouching out from the ventricle? Yeah, that would be an example of transependymal edema. And let's see here, sometimes it's also called interstitial edema. You can see it on CT scan, as I showed. Actually, flare imaging, you can see this is, this would be a T2 image. Comes out pretty well on a T2 image. This is probably this may be a contrasted T1 image, and you see it on here. But see the flare, this is another place where flare really shines, and the pathology really shines, literally. you see the flare has made the ventricular fluid dark, but amazingly, that fluid, when it comes out into the tissue, and I guess because it causes some kind of tissue reaction, it is bright. So this is really good for seeing the transependymal edema, and that can be important when somebody has hydrocephalus and you want to know whether it's obstructive hydrocephalus or not, because you often cannot see the physical obstruction. So you want to know what the pressure is, preferably before you do a spinal tap, to know whether it's obstructed. So that's very good for that. And that would be an obstructive hydrocephalus. And I guess I showed you this. You get the low attenuation around the ventricles of this and CT, but you get a halo, a T2, and flare. And just the advantage of flare is by blotting out this brightness here. I don't think this is the exact same picture, honestly, but you can make your transependymal edema come out very well. This is a table. Again, on these tables, I don't want you to memorize these tables, but to read them, and if you're doing something and you sort of forget what's what, you can see many of the things, not every single point, but there could be, but are listed here about the mechanisms of the different edemas, the CT appearance, the MRI appearance, and some examples on underlying pathology. And actually another example is medications. I think Dr. Gorman covers medications. I don't know whether she covers ones. Do you cover cyclosporin? You're not on this module, okay. Okay. That's one that can cause some cytotoxic edema. I may be able to find a slide to show you that. Okay, let's go to blood producing edema. And see, here's some intraparenchymal hemorrhage. By intraparenchymal, I mean like right into the substance of the brain. It's not subdural or epidural. I mean, technically it's subdural in the sense that it's below the dura, but it's not. Subdural means it's below the dura, but it's trapped between the dura and the next membrane and outside of the brain. Even though this is even more below the dura, we call it intraparenchymal hemorrhage. That means some sort of blood vessel here burst and you got a hemorrhage here in the brain, and around it you get some edema. And that's what something like that would look like. I don't think it's the exact same brain, but you'd get the blood and then the surrounding edema. Notice that this is a coronal slice and this is an axial image. Maybe I should have had them the same, but. So now here's tumor and blood. So that looks much the same, and the thing is, actually, this is another, I've got two different things written down here. Melanoma, hemorrhages from metastatic tumor. Oh yeah, the point here is that you really can't necessarily even see the melanoma. They know this patient has melanoma. This is a pre-contrast scan. So essentially all of this whiteness is going to be blood. because they've already told you it's a pre-contrast scan. So you're just really seeing the blood and the edema around it, and supposedly maybe the tumor is here, but I don't really see any difference myself. You really see the blood and the edema around it. Another thing you can get when you have edema with a stroke or for any other reason, you can get what's called a mass effect. In other words, it expands and it pushes other things in the brain around. And after you've looked at CT scans for a while, you can sort of start seeing this. You can sort of see that even though they're not totally symmetrical in the first place, but this ventricle is sort of pushed in a little bit. You can see there is a mass effect. Here this darkness here compared to the other side. So this is quite a lot of edema subsequent to a middle cerebral artery infarction. And on my talk on stroke next week, I will go through the difference between the different arteries and the strokes produced by that. But this one, it sort of makes sense. It's in the middle. Here's the front, here's the back, here's the middle. It's the middle cerebral artery on an axial scan. Here we see a subdural. It sort of has a crescent shape. And there's brain edema, hypoattenuation sort of around it, and quite a lot. It may be a little subtle, but you can see hypoattenuation, relative darkness here, quite a lot. And you can sort of see that this should be symmetrical, but you've sort of totally flattened the ventricle here. You don't even see it, and you even squeeze the other one over. Here's somebody who's had head trauma, and really what that has done is that you see edema on both sides. So this person has some kind of head trauma, and the brain has been so traumatized that it's actually swelling up on both sides of the brain. This is probably mostly cytotoxic edema, and it looks like it's mostly on this side, more on this side than the other side, and you sort of lose you don't see that much gray matter. You see more of a differentiation. You may have to look at these a lot before you can see it that well. I see some gray matter, white matter differentiation on this side, but less on this side, so I think there's more edema on this side. But the other thing, actually, the best way to notice it on this one is that, ordinarily a brain has sort of like sulcal markings, the sulci, the indentations. But if the brain is really swollen, you can see it just sort of flat against the skull. There's not many markings here. So, and there's the same thing here. It's swollen here, it's pushed over. You don't see many markings. If we go back to another picture of the brain, here you can see, again, here, this side is relatively normal. You see these sulci going in. Here, the edema has blotted them out. You don't see them. If this were to push more and more and more, it would then squeeze these out too. You see, this one isn't squeezed over so much, so you still see these markings. But on this one, it's squeezed over so much you don't see these indentations. And this on both sides, really. You see a little one here. Another reason why I think it's worse over here than over here, but it's too smooth here, actually. And now here is diffusion-weighted imaging. Here it shows the difference between T1 and diffusion-weighted imaging of a stroke. You can see how well that turn shows up, whereas you really don't see any difference at all on your T1, and I don't think you'd see one on an ordinary CT scan either. So let me go a little bit into the pathology, and Dr. Hussain has given you some pathology, and I'm trying to correlate that with what he has given. Here's an early, even 6 to 8 hours, or really I might as well just say 0 to 12 hours. So often you call 0 to 6 hyperacute and 6 to 12 acute, but they're all a type of acute. And usually you don't see much with an acute ischemic infarct. That's why the main thing you're looking at is the clinical findings that alert you to the fact that it's probably a stroke, and then the absence of blood, and that gives you a lot of information right there. Now, if you look real closely, I think you can say the social markings are a little better here than they are here. They're a little bigger. Maybe this density is a little bit less here than here. It's really subtle. If I were to look at this and think I had to say which side the stroke was on, I think I would say it was here. But even at this stage, even the micropathology is likely to look normal, or maybe the neurons would just start looking at the microscopic level a little bit swollen. But I got this from Dr. Hussein, and he feels this is still looking normal. But then if you go to the diffusion-weighted image with its corresponding ADC image, at the same stage, you see this really coming out. So you might even ask, well, why don't we do diffusion imaging for all strokes rather than CT scans? There are some places that are set up so well with scanners that go as fast as possible that do that quite a bit. But for most hospital work, it is much cheaper, it's much faster. And again, a lot of these patients with something like that, they're confused, they can't hold still, and you wouldn't get a nice looking scan like that. Here is something you can detect it on a T1 if you give gadolinium. This is probably a somewhat later stage where you start having some leakiness of your blood vessels, and the dye is extravasating. In fact, this is probably quite a bit later, because initially you just have more of a cytotoxic stage and you don't have that much leakiness of your blood vessels. So this is enhancement of a stroke, and I don't exactly know the age it's supposed to be. But you can tell that it was given contrast enhancement because you can see blood vessels all over the place. Now here's another example of early stroke, probably in the 6 to 12 hour area. And this is another one. It doesn't show much, but again, if you look and you can see some subtle things here, you see a little something here. This could be a little edema, or what it could simply be is the loss of the gray-white differentiation, because when you go into the sylvian fissure, then you've got cortex on either side. So this is gray matter here, and then it goes into white matter. And here you sort of lost it here. So this really does look like there is a stroke on this side, even though you don't see much. Also, see, this is sort of smooth here, whereas this you can see the sulci better. So subtle evidence of edema. I think if we put something like this on a test, I would try to have some clues to clue you in some way that you're supposed to look for some subtle signs of edema. Try to make it reasonably doable. I don't want you to think I'm going to put something on there that is going to be unnecessarily tricky. Inevitably, whatever's on there, somebody will find it unnecessarily tricky, but hopefully most people won't. Okay, here's another example. This is an interesting example of a stroke which is seen very, very well on the DWI scan. And this could be of any age. It's probably reasonably acute. And here is a corresponding CT scan in which, again, you see subtle things. Like you can sort of see, you see this where I'm outlining, and compared to here, this is darker. So that's probably edema developing. But then there's something else which you occasionally see, and this is really interesting. See that little dot there? That is most likely a branch of the middle cerebral artery with a clot in it, and you're seeing the clot. And it is sort of interesting that you can sometimes see the clot itself. And when you know, part of it's, yeah, could this be a fleck of calcium? Yeah, sure, it could be. But here, let's say the person, this is the right side of the picture, left side of the brain, so the right side of the person. So he's got a stroke, weakness, sudden weakness on his right. This looks a little less dense. There's this little thing here which looks very much like it could be an artery that's plugged up. There's a really, really good chance that even without going to an MRI scan, that's a middle cerebral artery infarct. Now, here's some more on flare. I think this is just sort of repeating some things. The ordinary T2, the fluid signal, is white. And also things like inflammation or stroke or edema due to stroke is white. But then when you use the magic of flare, you make the actual large fluid collections go back to black. But the things like stroke still show up as white. So this is actually before there was DWI, this was the most sensitive thing to pick up an early stroke. Here's a little later stroke. After 12 hours to 2 days, you definitely start seeing more attenuation on the CT scan. It sort of correlates with, got this from Dr. Hussein. It just looks a little darker. I mean, obviously the patient was dead or you wouldn't have this gross pathology, but this side looks a little more shrunken and darker than the other side. And then you get the red neurons. If you look through Dr. Hussein's SLM, he talks about the red neurons. Well, what do we really mean by that? I mean, actually the reason they're red is really the stain. I mean, it's like if you didn't stain them, they wouldn't be red. That's one thing to understand. This is like a H&E stain, a hematoxylin and eosin stain. So the whole thing looks red. So, but what we mean is that they look maybe a little more intense red and they're shrunken. And the real thing you can see is not so much that they're red, at least in my opinion of the pathology. Let's go back to, see if I can find his normal one. His normal one, that's red too. But this sort of area around it, which is, I think, partly, I don't know, partly some surrounding tissue, and you sort of look at the relative size of this white halo, and you look at the shape, and it's sort of like a nice, to me, nice shape with this tail on it. And then you go over to here. If you had to distinguish, you look, these look much more shrunken down and contracted, don't they? And look at this white area is much larger in comparison. This looks like something that used to fill this whole space better, and now it's sort of shrunken down. To me, that is to tell the classic red neuron is more that it's shrunken rather than it's red, because you get the red really from the dye. At least that is the way I can tell. I can't tell a different degree of red. Can you tell a different degree of red on that? But don't these look shrunken compared to the other one? Yeah, and if you look back and forth, and sure, somebody could pull out slides that would fool you or fool anybody, but on the test we're going to try to pull out slides that will lead you to the right answer. Okay, here's another one, 2 days to 2 weeks. Again, you start seeing a lot of visible pathology on the CT. This is gross slide, which is supposedly in that, and you see sort of like, looks like damaged tissue. And this is from Dr. Hussein. I'm not actually sure what that is. This is a blood vessel that is filled up, look like either clotted blood or eosinophilic material. This is probably, all these nuclei are probably glial cells, probably some gliosis, which is forming, and that's probably myelinated, an area of myelinated tissue, which is probably damaged because you see so much white there, so it's sort of contracted and shrunken. And here is a much older one, which you see it's sort of gone to the final stage. The bottom material has just died off, been removed by phagocytic cells like microglial cells. Here on micropathology, you see sort of areas that look empty, but which are probably filled with fluid. And here you can see in the CT scan the corresponding area, which is filled with mostly fluid and maybe a few glial cells and other things like that. Okay, MS. You heard about MS from Dr. Lambert, and I'm going to tell you a little more and show you some MRI pictures and some pathology pictures. The arrows are pointing at regions of demyelination which are very close to the ventricles, which is a very common thing in MS, and one of the signs of MS on MRI scan is that near the ventricles you get areas, little patches, sort of like fluffy little patches. There, you can see, and this is a T1 scan, and they would look sort of dark on that. They're much easier to see on T2 scans, however, they look very bright. In fact, this is probably a flare because this is probably fluid in the ventricle that looks dark, and so you can see all this stuff. To me, it looks sort of like clouds or puffs of smoke or something like that. And that's a very characteristic pattern. And you can actually see some of it. I think I see some, this is the cerebellum down here. I see some in the cerebellum as well. But definitely all this white fluffy stuff, or it looks a little like cotton. It looks like cotton, and if you take a ball of cotton and you sort of pull it out, and it looks sort of like that. And here's another example of a plaque. And then here's a myelin stain. The myelin stain is the blue. This is probably a stain called Luxol fast blue, but you see it's really denuded of that stain, so your myelin has broken down. There's not much of it left. And here is a scan of a similar patient, if not the same, in which, and this would again be a flare because, well, this would either be when you can see the ventricles is black, it's either a flare or a T1. Generally, you know from what it says, and I think this says FL, I think that's part of flare. And flare just looks a little different than a T1 in other ways. But I think this is a flare scan in which you see the pathology here, and you see it very distinct from the ventricles, but very near the ventricles. So here is going to be a patient with MS who got a routine scan during a research study. Oh, I guess this is somebody who was, had no active symptoms, so I guess was doing okay. T1 image, no contrast, enhancement, and arrows show demyelination, okay. So, seeing here, again, that's sort of the same scan. And when we say no contrast enhancement, it means the patient was given gadolinium and it didn't add anything to it that you didn't see. Usually you look, okay, this is the flare. This is a little unclear the way this is stated. This picture is the flare. In fact, I think it's the exact same picture we had back a few pictures ago. Yeah, I think that's the same one. That's the flare. And it's just telling you that in addition, a T1 weighted image with contrast was done, and that would show these sort of as dark, and they probably wouldn't show them as well. They'd show them a little bit. But then, if there's no contrast enhancement, it means those are probably old lesions, that the lesions aren't active. The active lesions tend to show contrast enhancement, and I may have a scan later on, or if not here, I've got it when I give the whole talk on MS, which will show that. And that's a way of distinguishing between a lesion from an acute attack and just an old lesion, is to do a T1 scan and then add contrast. You usually give the contrast to the T1 scan because the T1 scan otherwise won't show lesions as bright, so you give the contrast to make any lesions turn up bright. And here's just another picture sort of correlating. Both of these now are axial scans, and here these sort of gray areas or brownish areas are the demyelination on the pathology, and you see sort of corresponding areas. And I think this is the same brain. And here, again, is the same brain, and this is I guess this is a T2 scan. You see these fluffy areas here, a lot of demyelination. Now I wanted to show you this picture. On Dr. Hussein's SLM, he shows this picture of white matter, and you can see, you see these little strands. Those would be the myelinated axons. They're going here and there and everywhere. They look like they're all a tangle, but probably each of them is going to some specific place, and there's just so many of them, it looks like a tangle. And he didn't happen to show that I could see what, like a specific contrast between that and a myelinated good area and a demyelinated area. So I found this one with a somewhat different stain, a bluer looking stain. But this would be the myelinated one. And then this would be the demyelinated one. Now, these are different magnifications. I don't know if I'd have to, if I want to manipulate the magnification, I have to somehow show that turns it off. So I guess I can't do it that way. The thing is, if you, maybe I can put this picture in a downloadable form. If you take this little square of it that I carved out, and in the PowerPoint, make it larger, it really does look like this over here. And you can see those same myelin strands, but then you can see there's very few of the myelin strands here. On the lower power, you can't see it. The lower power is so you can sort of see the difference between the area that's good and the area that's demyelinated here. But then if you want to see the little myelin strands, you can see them a little bit here, but it's better to look at a higher power. Did everybody understand what I was saying there? Yeah, yeah. Yeah, because this is a slightly changed version, so I'll post this maybe by tomorrow or sometime. Yeah, yeah, and you can. You'll notice if you. I was playing around with this. You just sort of grab the corner and pull this thing out until it's real big, and then you get something that looks on the good side. It looks very much like this, except it's a little different color. I was trying to change the color. I couldn't get it to that color, but and then you see the demyelinated. Sort of interesting too that you can do microscopy now is being done digitally. You can actually take very fine-grained images, and you can blow them up a lot, hundreds and hundreds of power, just practically by doing that, by just enlarging the image. Oh, and here's just another example of demyelination. This is actually a patient who had recent bone marrow transplantation and then got a syndrome which involved really some visual problems, and this is in the occipital cortex, and some other issues. And I think there's some swelling around these areas. And these are demyelinated areas generally in the posterior part of the brain. And this is a fairly recently, and also she had seizures. This is a fairly recently discovered syndrome called PRES, or posterior reversible encephalopathy syndrome, as a temporary reaction to something like some kind of medication, often the transplant medications. Sometimes cyclosporin will do that too. And cyclosporin is a transplant medication. It'll at least temporarily cause some demyelination, but it seems to be reversible. And then if a person is not exposed to those drugs again, it won't be like MS and go on with subsequent attacks. But that's just to show you that there are other things that cause demyelination other than MS. And here is something again. This is online. Is this cytotoxic or vasogenic? Okay. Yes, and the reason is that there's sort of a thin, you can still see that thin rim of gray-white differentiation around it. Maybe a little thinned out just by getting pressed by the pressure, but the sparing of the gray-white differentiation generally means that it's vasogenic. Now, is this a hemorrhage or a tumor? Yeah, it is a hemorrhage. Now, the biggest way to tell for sure is now, on this version of it, it's labeled left frontal bleed with, that's the most certain version, and it was done by somebody who really knew how it was done. When I look at it, I say, well, this, first thing, is this contrast or not contrast? I think this is just calcification here, because it isn't very bright. And therefore it's non-contrast. If it's non-contrast, the tumor wouldn't show up as bright at all. And so what would show up as bright, the most likely thing is blood. Now this could be a huge piece of calcium, but I've never seen a huge piece of calcium like that in the brain. So you could argue that if you didn't have any other information that this was a contrast scan, and then the tumor had a lot of blood-brain barrier breakdown. This was a tumor, and this was some additional edema around it. But I think it's more likely that something like this would be hemorrhage. And if we had something like a question, I'd definitely make it clear whether something was non-contrast or give you a way to find that rather than guessing. Okay, here this is like this little dot thing that I showed you before. Well, I guess I'm telling you the answer, but the answer's online anyway. This is stroke. You don't see much edema or anything, but you see this thing looks like a little white worm in the brain. And what is that? Yeah, it's a calcified part of the middle cerebral, a clotted blood in the middle cerebral. And this you're seeing it more from the side, whereas the other one you were seeing it end on. And this is not that uncommon in middle cerebral artery strokes. Even when you see this, it's called the middle cerebral artery sign. And you may well see this on the wards in medicine and in neurology and in other fields when somebody has a stroke. And you may be the only one that recognizes that. You can point it out to people next year. Yeah, that's the middle cerebral artery sign. And okay, this is a 30-year-old woman. She's had intermittent episodes of weakness, sensory loss, and visual loss for about a year. What is the most likely diagnosis? Brain hemorrhage, ischemic stroke, multiple sclerosis, or brain tumor? Multiple sclerosis, right? And why? Why? Okay. Age, and it's also intermittent episodes. You could have intermittent strokes, but it isn't that likely you have intermittent strokes. So it's probably suggesting, like what Dr. Lambert was talking about, relapsing and remitting, relapsing, remitting. Each time you have it, you don't go quite back to normal, and then you get another one, and then another one, and another one. MS, okay. And here are the different types of scans. The T2. This one I didn't tell you about, a proton density scan. They're not used so much anymore. Wouldn't worry about that one. This is a flare. You can see it best on a flare. And this is the T1 with gadolinium. And see, this is something you could get with the T1 with gadolinium. Notice you see this is white, and there's some white stuff here. There's this, you see this, you see this, you see this. But look, here's something here, and you don't see that at all. Or actually, it looks a little dark here. And also, this is much bigger than that. And this one, you see a little something here, but you don't see this long thing. So what does that mean? This had contrast, and this doesn't have contrast. See, what this means is that when you do a T1 with contrast, the lesions you see as bright are going to be the acute lesions, which have a blood-brain barrier breakdown. Then when the lesions get old, they're no longer going to be bright on T1, and they're not going to have blood-brain barrier breakdown anymore. And if anything, you'll see a little bit of dark where the old lesion is. So the thing about the flare is it shows both old and new lesions, but there's still a use for the T1 if you add contrast to it, because that brings out that there are new lesions, relatively new. These are probably no more than a month old. And that can be very useful in allowing you to diagnose MS from a single scan. That's possible now, because you used to have to be able to show at least one relapse, like 2 rounds of it, basically, 2 attacks. Now you can actually do that in one scan if you can find, if somebody comes in with an attack, you do a scan and they've got some old lesions like this and like this, and then they've got some newer lesions corresponding to the current attack. You can say right straight away that they have old and new lesions. And in addition to that, they have them in more than one place in the brain. So even it used to be if somebody came in like this, and that was their first attack, you'd have to say, well, this is a good chance this is MS, but we can't tell until time has passed, in the next 6 months. If you have another attack, then it's probably MS. But you can pretty much do it straight away. And now that we have effective medications, reasonably effective, that's a good thing to know. Now, what are all these things? Metastases, that's right. And the one tumor, maybe not the only one, but one tumor which really has a tendency to produce multiple metastases is malignant melanoma. And that's what this is. And there's some edema around it. And actually, I don't know whether this is contrast or not contrast. In a way, this is sort of an example that you can have something bright from just the tumor. This has to be contrast. This has to be contrast. And I think I see some contrast in blood vessels here. So this lit up, and so this is probably leaking from the tumor, and then some additional edema, which has a little bit of contrast in it. So anyway, multiple metastases like that are not that uncommonly seen in melanoma. Okay, well, I think we've covered a lot of ground, and though you don't know everything about neuroradiology and its correlation with pathology and disease, you know something. And I think, if you go over these, you will find that you know quite a lot. For the pathology stuff, because Dr. Hussein could not be here, I also have a copy of his SLM with me here. And even though this is now, you're free to go, you're always free to go, but this is now supposed to be your study time. But if you want, I can work through some of Dr. Hussein's slides. I also have a clicker, some clickers related to Dr. Hussein's slides. I can go through them if you want to test your understanding of that, or go and study. I don't, I'll open these things up here though, and I'll even lecture if necessary to an empty room just to put this up here, just to go through his thing. But let me find them here.
But, you know, if you guys want to grab some of the brownies, I don't want them in my office, so if you want to grab some of this. Steve, did you ask them Tech if they would record? Because I know Matthew.
Yeah, I did ask him to record, so I'll just go over these.
Matthew said he was going to keep the recorder on a little bit later, so they should be on the recording, so. He has a link.
Yeah,
He said he was going to keep the recording.
sure.
Give him a little.
Good, yeah. A little bribery never hurts.
You guys were sitting in here and this is the Thursday popcorn.
Well, I don't know if anybody brought clickers because I didn't originally say clickers. So if you have them with you, I've got some clicker questions. Yeah, I'll put them up there. I'll put them up there, and they're actually originally mostly from Dr. Hussein. He's got his, when he comes back, he may have his own thing. I actually took some of his slides since he couldn't be here and, put them together to make something to substitute because, hopefully I've communicated with him. He seems to be doing well after the surgery. So before the surgery, you never know what's going to happen. Okay. Well, let me just go through some of these things just to see. Here's a man who got bone marrow transplant 10 weeks ago. He took some cyclosporin, which I asked Dr. Gorman about, to minimize rejection. And now he's got blurred vision. And what pathology is on his head CT? If you have clickers, maybe nobody has clickers. Just the one person. Okay, one response. I guess that's all we'll get as the response. What do you think? Cytotoxic edema. Okay, let's see. Interstitial edema. But really, it's vasogenic edema. And that was on Dr. Muji's, Dr. Hussein's thing. I think I actually think it should. Well, see, here's the thing, cytotoxic edema would be like what you get in a stroke, and you would not have this differentiation of white matter around here, whereas you have it with the vasogenic edema. So I think we're going by the appearance of that. This is something, I wouldn't put this one on. This was from Dr. Hussein and Dr. Bellew the previous year. I think this is correct, but I think this is a little bit too difficult for a test, and I don't think anything like that's going to be on shelf. Here's another difficult one. White matter biopsy. E is an erythrocyte. Here are some things that generally contribute to the blood-brain barrier. And which layer is the one that most contributes to the blood-brain barrier? Okay. And, you know, I did talk to Dr. Hussein about this one before he left, and he's sure that's right. I'm not sure that he covered it that well in his SLM this year. I don't think he necessarily thinks that's a super important point, but you could ask him when he comes back. If you happen to see this very same one, remember it's this one, the one that's closest to the lumen, is supposed to be the right answer. And what do we have here? Here we just have some examples of edema. And this mentions that this could be vasogenic edema from any cause. So I guess these are the edema from back at this one, which we said was vasogenic. And this is just some more on the edema, more pictures of it, and mentioning that it could be vasogenic edema from any cause. So the thing about vasogenic edema is it usually doesn't go all the way to seemingly connect up with the skull. You have this white matter left. So if you see that, it's not going to be stroke edema. It could be tumor edema. And honestly, I think from cyclosporin, you can get both cytotoxic edema and vasogenic edema. And I think it just happened this is a picture of vasogenic edema, which you can tell from the fact that there's this rim of white matter around it. Again, that's fairly difficult, fairly sophisticated question. Okay. So now the cyclosporin was discontinued, confusion improved, but he's now got very poor vision. Now what pathology is on the head CT, follow-up head CT? Okay, got all our responses in. 100% turnout. Okay. Cytotoxic. And yeah, because you see now, this shows the difference. Exactly why you get that, I don't know, but I think this was taken from a case report of a person who had both, one after the other. And see, it goes all the way out to the skull. I mean, there are actually some layers in between this, but it looks like it's right next to the skull. And that'd be cytotoxic edema. And this would be sort of as a delayed reaction. So again, the guy has had both, and both apparently from cyclosporin. And this is supposed to be an example of pathology of cytotoxic edema. And how do we tell? Well, I see swollen cells here, and that's what you get in cytotoxic. And sometimes it's hard to tell the outline of the cell, but I see they look sort of swollen. maybe some abnormal glial cells. It's, now here's one. Here's an example. This is just an example, not a question, of interstitial edema. Here's on ordinary CT scan. Here's a T2 MRI scan. And here is a flare MRI scan. On your right is the flare. And on your left is still the CT scan. See the difference between a T2, you can see it, brings it out, flare, much clearer. Okay, here, oops. I guess this says what is the lesion, but it isn't on the, hold it. Why doesn't this show where the lesion is? Let me try again. I can't even. Okay. Well, so much for that one. I don't know why. I can see it on mine. Oh, wait. Next. Okay. There's the illustration. Okay. Where is the big lesion? Okay. Oh, this is obscure in the graph, but yeah, that's right. And what of these three possible things is the main primary lesion here? That's right, blood. And here's an example. So we're trying to correlate pathology and radiology. Here's this on the gross pathology, and you saw the radiology, and there's the rim of edema. This is the same illustration I had before. Another large intraparenchymal hemorrhage. Shows it on the CT scan. Now this is just showing what can happen in raised intracranial pressure and herniation. We have later on a section on trauma, which will, I think, show this. I think this is by Dr. Patisipu when we go over trauma. But I just put this on here. When you've got a lot of pressure, you get something called herniation, which means basically the brain gets squished one way or the other by the pressure. And these are sort of like the three main types. You often get like a combination, but there's this area here is the falx. So you can get the subfalx herniation. I think I'm going to sit down because I haven't had lunch and I feel sort of sick here. This is the subfalx, transtentorial. This membrane is the tentorial membrane, so it can squish down here. This part of the brain is called the uncus. And these are the cerebellar tonsils, and they can squish down too. Now, what artery is most likely to be compressed with the subfalcine herniation? I can't see the, let me just do it here. Yeah, anterior cerebral is up in that area. With the uncal herniation, and by the uncal herniation we mean that one. Posterior, I guess we didn't produce a graph. So what type of herniation is the predominant one in this image? Subfalcine, let's see, here's the, oh, not my arrow, here, okay. Here on here is the, I guess on the panopto they can't see this thing, but here is the area of the falx. So that's very much like, let's go back. It's just in the opposite direction. It's very much like that picture there. Go back to this, okay. Another example of diffusion imaging. Here, the same thing that I showed on acute stroke. Showing you can see it on the flare. You can see it both on the T2 and on the flare. And the only thing, it doesn't make that much difference on this one because it isn't that near the ventricle, but you can see it on both. And now here you can see sort of a difference. Dr. Hussein's thing. See, you can see these are sort of bigger. This is supposedly the same power, I guess. And you can see that white around them. The rim is much larger relative to the size of the neurons. And some of the neurons, I don't know if that's a neuron or some kind of an activated glial cell. It looks like it's got 2 nuclei. But if you stare at this enough and that enough and ones like that, you can sort of see that this is the abnormal one and that's the normal one. Here's the gross pathology. Actually, I think this one is actually flipped around. Here, this one is on the right side on the brain, and this one looks like abnormality is marked on this side of the brain, but really this looks pretty subtle. If you look here, you look here, there's not much of a difference. We can ask Dr. Hussein about that one when he comes back. I'm honestly not too impressed by that slide. But anyway, here's the here's the neurons. More gross pathology. We've really seen that slide before. I think he's just trying to show some something sort of more preserved there, but you can see areas of damage. There's areas of damage on the pathology, and then damaged cells in the micropathology. Here's swollen axons, well, swollen neurons. I mean, that obviously looks swollen, that big fat one. Swollen axons. Now, these are obviously two different views, but I guess this is swollen. And maybe there's also big empty spaces between the myelin running. It's a little hard to compare these two, but this is supposed to be a swollen axon. This is just something on the brain edema. After a stroke, you mostly get cytotoxic edema, which is why it got stars by it. But you actually later get vasogenic too, and so it sort of adds together and makes the ultimate peak of the pressure a little later. And some books put the cytotoxic edema as occurring a little sooner than, as peaking a little sooner than that, like about maybe 2 to 3 days. But this happens to say 4 days. And here is the, I think we've seen that before in another setting. So this is another clicker question. What pathology do we have here? Now this sort of is tricky. We're not really looking at the edema per se. This is a contrasted T1 scan. So we're looking at the fact that there was an extravasation of the dye from the blood vessels rather than the fact that on vasogenic edema, you wouldn't see, if this were just the edema, you wouldn't see the obliteration of the gray-white junction, but when you're just looking at the dye extravasated from the blood vessels, the dye comes out. I think that's the thing there. That wasn't what I put together. I didn't put that question together, but I think that's the reason why that's vasogenic edema. If we're cytotoxic edema, you really wouldn't get the leakage of the dye. They're just some examples of gliosis, normal white matter. Here, I mean, these are different stains, so it makes it sort of hard to compare. Early gliosis, what shows that it's early gliosis? Maybe some of these little cells or glial infiltration. Whereas we'll see these cells, mostly these are oligodendrocytes. So we got to see this. Here's all these little nuclei here. I think that's some infiltration with microglia. And now we're getting some fibrous astrocytes. Though you could ask, how does that differ from the fibers you see in the myelin? We certainly don't see as many oligodendrocytes, though. And then here, definitely something is wrong here. You've got all these white areas where you've lost a lot of tissue and just these fibrous astrocytes later. Also, if this blue is a myelin stain, then we're not seeing it anymore, but I don't know whether he stained it for myelin or not. I showed this chronic stroke one before, just showed this heavily damaged area, loss of neurons, loss of neurons. And this just shows normal myelin. Normal, see the oligos. Here's the Luxol fast blue stain. You see there's a lot of myelin there. Oh, here's one that shows the differentiation, okay. Normal, and here, see, Luxol fast blue stains this all blue, but virtually none in the demyelinated area. Here, silver stain. I think the point here is the silver stain stains axons, not myelin per se, but axons. So you might say, oh, there's no axons here at all, so something else. This just all disappeared. But now when you do the axon stain, there may be a little bit less density of axons, but basically there's a lot of axons here. They're just not myelinated. So that's a good comparison here. You can really see normal, normal. Just from the point of view of axons, it doesn't look too abnormal. maybe mildly abnormal, a little bit less. But then when you look at myelin stain, wow, just gone. There's MS plaques here by the horns of the ventricles, and here's using the myelin stain. And here's probably more myelin here and less myelin over on the right side. And reactive astrocytes, how would you know they're reactive? Macrophages, lymphs. I'm not a good enough pathologist to pick out all these, honestly. And we could ask Dr. Hussain when he comes back what's what on here, but this is supposed to be reactive astrocytes, macrophages, and lymphs. And here is T1 without and with contrast. This is obviously the one without, and this is with. And you can tell it's with because you see these little blood vessels here and there that are filled with the dye. And here on the without, this is dark, and it's got something a little bit lighter around it. But then you see just this brightness here. So what is this? You get a chance to decide what is that. Vasogenic edema again. So this is another case of the dye extravasates here, lighting this up. And I guess the rim actually is more of the vasogenic edema. Let's see the size of this thing. Well, it looks like it's more the center. I don't know, but it's extravasation and dye, I guess, is the key. You do get that frequently with vasogenic edema. The blood-brain barrier breaks down. More MS, maybe the same slide. Here's demyelination on the corners around the ventricle. And on the MRI scan, you can see the demyelination. And now you see the difference between two different techniques. Here you see the flare brings it out better. Yeah, interestingly, I wonder, Looks like the flare picks up some things the other doesn't. I think it's just the sensitivity. I don't think that shows that's an acute lesion. I think for that they'd show a T1 with gadolinium to show acute lesions. I think it just shows greater sensitivity. Anyway, here, is this the same one we've seen before? Let's see. No active symptoms, sagittal flare. Oh. Okay, this will now explain. No contrast enhancement. So what pathology is most likely demonstrated with the arrows? Gliosis. So, and I think that the reason is that they're telling you the sagittal, okay, this is the sagittal flare, which is depicted. And then they tell you, in addition, T1 weighted imaging with contrast showed no contrast enhancement, so there's nothing acute. And without an acute lesion, you really wouldn't get any kind of edema, either cytotoxic or vasogenic. So most everything that you see here is going to be like old damage, which would be damage to the myelin and some damage to the axons and sort of filled in with gliosis in a subsequent repair process with a lot of excess glial cells. So that was the point of that. Here's something that shows damage on the path slide and damage on what looks like the same section on an MRI. And then when we do the T2, we see things as brighter. Let's go back, but you can still see pretty much everything. No question associated with that, but I think it just sort of shows how well you can see with the T2. And if we did a flare, this stuff in the ventricle would go away and you'd probably see it even better. And probably this is, well, we'd have to get the story that goes along with it, but this is probably gliosis, though if it enhanced, then it would probably be if it didn't enhance on a T1, then it would be a vasogenic lesion, and it would be a fresh lesion. So, okay, I'll stop here. I think these are more difficult than Dr. Hussein's SLM. These were sort of gathered from previous years, and I think they're more difficult, but hopefully they help your understanding of this. I think as you look at this more and more, it'll make more and more sense. Let me grab this out. Okay. Let me just. Let's walk off with their